Hello, my name is Rani Octaria. I'm the primary presenter for this poster. In this study, we compared patient characteristics and mortality of CRE cases with and without carbapenemase production using a retrospective cohort of 1,200 patients who are CRE cases or Tennessee residents. So CRE are associated with poor patient outcomes. It is an antimicrobial resistant organism, and if the CRE produces carbapenemase, it possesses a mechanism conferring genes in the plasmid that can be transferred to other bacteria. In Tennessee, reporting and isolate submission is required to do confirmatory testing and carbapenemase testing. However, the characteristic and mortality risk associated with this production has not been found out. So in this study, we conducted a data linkage of hospital discharge data, vital registry, and our CRE surveillance data, and found that the largest proportion of CRE cases were non-CPCRE, so they did not produce CPCRE. And Klebsiella is the most common among CPCRE cases. We found that resistance to meropenem, incidence of bloodstream infections, comorbidities, and prior healthcare exposure were more common among CPCRE cases. So they are more likely to have gathered these infections in healthcare settings. So CPCRE patients had higher 30-day and 1-year mortality rates. So when we follow up their vital registry, we found that within 1 year, 26% of CPCRE cases died, and within 1 year, only 14% of non-CPCRE cases died. And then we did some regression after adjusting for comorbidities, healthcare exposure, and other confounders. CPCRE patients had an increased risk of 30-day mortality. That risk is 56% higher with a confidence interval that are not crossing 1, so it's significant results. The same could be said about 1-year mortality. So carbapenemase production is associated with increased risk of 30-day and 1-year all-cause mortality among CRE cases in Tennessee after adjusting for other confounders that may influence this association. Thank you.